Pharmacology Exam 4. This is a lecture on cell wall antibiotics, and it's from the perspective of what would you give in the case of this disease or this situation. So starting out, we have the case of abdominal abscess. A patient presents with an abdominal abscess, and they have an allergy to beta-lactam antibiotics, and you test the abdominal abscess and you find that it is gram-negative aerobic. So a person has a gram-negative aerobic abdominal abscess and they're allergic to beta-lactam drugs, then you're going to give them something called monobactam. And monobactam has a different structure than the beta-lactam. And the drug here is called aztreonam. I think aztreonam kind of sounds like Aztec. So here is an Aztec warrior, and he is being shot in the arrow, with an arrow in the abdomen, to help you remember that it's aerobic and abdominal abscess. And he has red splotches all over his face, to help you remember mono, because mono is the kissing diseases, so he's been kissed all over his face. Got mono, and it doesn't really have anything to do with mono, but monobactam kind of sounds like mono. And it only works with penicillin binding protein 3, and I don't really have a way of memorizing that, so good luck. Next we have the next disease. So a patient, this time they present with an intra-abdominal abscess, but they find that it is not a gram-negative aerobic. In fact, this situation, so it's not gram-negative aerobic, and they don't have an allergy to beta-lactams. So in this case, you could give them one of the Carbapenems. Okay, so the way that I thought of memorizing that is, oh, by the way, with Carbapenems, penicillamine proteinase is the target, and these are resistant to beta-lactamase. And the image here I drew was this guy had a big abdomen, and it looks like there are donuts poking out of it because it's inside of his abdomen. The carbs like donuts inside of his abdomen. I don't know. He has a little cross around his neck because it looks like a positive sign for gram positive, because this is good for gram positive. You don't use it with gram negative. And so another thing too is if you think of all the carbs, you might think allergy. So you think maybe him being like, some people are allergic to gluten, and sometimes they're allergic to all kinds of other things too. That's kind of a stretch, but basically you think that if they are allergic to beta-lactams, then you do not give them Carbapenems, because the Carbapenems are really similar to beta-lactams as far as allergies go. So next we have the case of a patient comes in with a systemic infection, and it could be MRSA, or I guess it could be Clostridium difficile colitis. It's going to be most likely gram positive. So in this case, you're going to give them vancomycin. And vancomycin disrupts the D-ala structure of the cell wall, and giving someone vancomycin can cause something called red man syndrome, which is not an allergic reaction, but it's basically the releasing of all of the contents of the histamine, releasing histamine, which makes a person turn red. And it has nephrotoxicity. It's H2O soluble. Because of that, it has really bad penetration into the CNS and into the lungs and through the GI. So poor penetration is H2O soluble. So for this one, to remember it, I drew Mrs. A, which stands for MRSA, and she is too claustrophobic to get in the van to drive people around. So she has a little cross around her neck to remember that's gram positive. And Mrs. A has a picture of or has a red man on her van. I don't know. I'm tired right now. Okay, so next we have a person who has a drug that is vancomycin resistant, okay? Or it's vancomycin resistant Enterococcus, or it's vancomycin resistant Staphylococcus aureus. Apparently the Staphylococcus aureus, through they're thinking maybe the plasmids, gave the immunity to the vancomycin resistant Enterococcus. But anyway, if somebody comes in and they have that, you can't give them vancomycin. You probably can't give them anything else either. So what are you going to give them? You're going to give them daptomycin. And daptomycin works because it is porin forming. So it forms a pore in the cell wall, and it is not nephrotoxic, but you don't use it in the case of pulmonary infections because it will bind to the surfactant in the lungs, and that's bad, okay? So do not use daptomycin in the case of pulmonary infections. And the way to memorize it is, I think it's porin forming. I have daptomycin kind of sounds like tap water, and it's pouring out of the tap water, so porin forming tap water. Okay. Next we have, I just threw these three drugs together because as far as what they do, it seems like it's just the same thing as vancomycin. As far as I can tell, I don't know, I was reading up on it, I couldn't find much difference. So telivacin, dalbavancin, whatever, and orbitavancin. So the only difference really is these two have a ridiculously long half-life. It's like 10 days. Telivacin, he's really into it says like black box and all bold. So apparently it's like a class C, which means it did cause some like mutations in animals when they were pregnant, but none's been found in humans yet. So we probably don't want to give it to pregnant women unless you have like a really good reason to do that, just because it's been shown to cause mutations in animals. It's nephrotoxic and also has a QT elongation. So since it's telivacin, I thought maybe television kind of sounds like telivacin, and here's Mrs. A watching television because it works for MRSA as well. Same thing, like vancomycin is good for MRSA, and then if it's also these are good for MRSA as well. So next one we have here is if a female patient comes in, she has a very complicated case of urinary tract infection. You're going to give her something called fosfomycin. So fosfomycin, it gets excreted out through the kidneys really quickly. And so I thought maybe phospho kind of sounds like fast flow. Fosfomycin. So fast flow, think of urine flow, UTI infection coming out really fast. And enol is that I don't know, it's just kind of a stretch. Anyway, yeah, so enol pyruvate. So yeah, transferase, fast flow. Just remember that. I don't know how you're going to get that last part out. But next here we have a person who, I don't know exactly how this works, but apparently like cleaning out like topical wounds, or like maybe a topical abscess or something, or like what do you call it, like rinsing a wound of some kind. You can use bacitracin, and that works for gram-positive, gram-negative just fine, but it's way too toxic to actually like put in somebody's mouth or like inject it through an IV or parenteral or whatever. Way too toxic. And the way that it works is the dephosphorylation of lipids. So it like kind of shuts things down. And bacitracin, I guess you can think that it's just for tracing wounds or infections, not actually like going inside of the infection. So it's just on the outside, external use only. Next we have a patient who presents with drug-resistant tuberculosis, and for this one you'd use cycloserine, and this one is like a D-alanine analogous kind of thing, so it inhibits D-alanine, and if you give too much of it, you can cause CNS toxicity. And I was just trying to think of like TB, maybe kind of think terrible cycloserine. I don't know, kind of a stretch, but hopefully that helps.